Hello, my name is Kristy Henson, and I'm here today to talk with you about a small portion of my Ph.D. called Biocultural Variables and their influence on vitamin D deficiency in the recent historic past. So the purpose of this research is to determine if biocultural variables influence the expression of vitamin D deficiency and if vitamin D deficiency leads to an increase in spinal fractures. So for today, I'm going to be kind of talking about this first part. So what is vitamin D? Vitamin D is a prohormone. It plays one of the largest roles in calcium homeostasis. So calcium needs vitamin D so we can absorb it from our gut into our blood. That excess calcium is then stored in our bone. So it plays a really large role in our bone health. So we get vitamin D through foods and through UVB rays from the sun. Now, if we don't have adequate vitamin D, that means we don't have adequate calcium. If we don't have adequate calcium, that's going to lead to some metabolic bone disorders. Ones that we are talking about today would be rickets and osteomalacia. So rickets is vitamin D deficiency in children. So if we look at this image here, we have a femur, a tibia, and a fibula from a child. They have vitamin D deficiency, so it changed the shape of the bone. Due to gravity and weight bearing, lacking of calcium will create weaker bones because of that more present collagen matrix and less of that crystallized hard matrix. So that bone's going to deform. On top of deforming, we get flaring of the metaphyses of the bone, so near that growth plate. So it's going to become abnormal. On top of this, the bone density then decreases. When we have a decrease in bone density, that's going to increase fractures. So less force is going to be required to cause fractures in certain bones on the body. Other things rickets you'll see would be like striations in teeth. Now, if rickets and the bowing of the bone is severe enough, it leads to residual rickets. So if you see down here, this individual has residual rickets, which means that deformity or that change in shape of the bone was so severe or long enough that this morphology maintained in adulthood. So I still see that abnormal bowing and I still have those flared or enlarged ends of those long bones. Now, if you're an adult and you're vitamin D deficient, it's called osteomalacia. So what this does again is it decreases the density of the bone, increases the chances of osteopenia, and decrease in bone density increases fracture risk. On top of normal fractures from, say, everyday life, they can develop these small subtle fractures which are called pseudofractures. These are going to appear on places where there's a lot of normal force. So on the os coxa, the scapula, necks of long bones, anywhere we have a normal amount of force, but that decrease in density can cause fractures. Also present on the ribs. So why do we care? Having abnormal shaped bones or fractures is not good. So we want to make sure we have a lot of vitamin D, chances to absorb vitamin D so we can get that calcium and have healthy bones. So there are a lot of things that can affect our ability to absorb or intake vitamin D. So all of these are different variables, biological and cultural, that can influence our exposure to UV or our diets. So your weather, where you work, where you live, how old you are, your cultural behavior, lifestyle, your social status, if you live in an area with a lot of pollution, what you wear, your sex, your ability to access certain resources, all of those can influence your ability to absorb UV from the sun or eat foods like fortified milk that contain vitamin D. So for this research, I'm going to be examining a lot of these different biocultural variables, which go into my materials and methods. So I did a ton of stuff. So first, I macroscopically analyzed skeletons. So these skeletons were individuals who were documented or known. The known individuals were located in the Hammond-Todd and the Stanford skeletal collections in the United States. So the Hammond-Todd collection represented individuals who died in Ohio, up here in northern Ohio. The Stanford collection represents individuals who died in Santa Clara, California, which is around northern California. that will be relevant in a couple minutes. I had to have individuals who were known or documented because that allowed me to identify them through their death certificate information and other census and genealogical information. So for each analyzed individual, I tracked them through the census record, compiling their life story. So I started with death certificate information that I got from FamilySearch.com for each individual, then used that information and cadaver logs to pull their census, military, marriage, immigration, any records I could find from Ancestry.com. Now, on top of that, I extracted historic and modern weather data for the 48 continental states, splitting the states into North and South based on the location of the Mason-Dixon line. So that gave me 48 states, and then evenly split into North and South. From there, I was able to pull temperature, so in Fahrenheit, the UV index, so the strength of UV every day, the zenith angle, so the angle in which the sun penetrates or shines and emits rays onto that state and that location, the average altitude, number of sunny days, average rain per year by inch, and I always split those into different seasons and then as a total for each state. So on to some results. Here are some of my weather results. So here I combined all of my seasonal data and North and South. So this is the average for the southern states and the northern states. Only a few were significant. UV index, temperature, and zenith angle were significant between northern and southern states. Rainfall and clear sky days were not significant. Now, I also compared all of this data. When I compared it all via ANOVA, looking at columns, so looking at all 48 states, there was statistical significance. But when I combined it and looked at just North and South, the results were not significant. And then again, when I looked at just Ohio and California, which were my two states of interest, they were not significantly different, even though one is in the north and one is in the south. Now, demographic results. I was able to analyze 160 individuals in the Hammond-Todd collection, a relatively even distribution of age and sex and social race. The Stanford collection, I only analyzed 17 individuals out of the over 200 because of the fragmentation of that collection. That collection's severely fragmented, and they didn't have a lot of vertebral columns, which was one of the other portions of my PhD. So again, I was only able to analyze 17. They were all white, and most of them were male. So getting into what we care about today, vitamin D deficiency. So in order to be considered positive for vitamin D deficiency for my sample, I used the modified Istanbul protocol, where I required a certain number of lesions to be present to be considered highly consistent or consistent of vitamin D deficiency. If they had some of the lesions associated with vitamin D deficiency but didn't quite meet my threshold, they're put into the category of potentials. So my confirmed categories for osteomalacia are here and residual rickets are here, and then my potentials. So I ran my data with my knowns and my potentials. Here is presence of vitamin D deficiency and different biocultural variables. The stars on the top indicate significance using chi-square, looking at the intersectionality of variables. So north and south, this would be lived childhood. So they grew up and spent their childhood in the north or the south. These were considered statistically significant with vitamin D deficiency and with residual rickets. Sex and social race were not considered significantly different. I also looked at vitamin D deficiency in occupation. Each occupation did have one, at least, individual that was vitamin D deficient. As you can see, the majority were blue collar, followed closely by housewives. None of these were statistically significant. Others that did have some significance, if I looked at vitamin D deficiency as a whole, date of birth, date of death, and where they lived their childhood, when I included my potential individuals, was statistically significant. If I looked at osteomalacia on its own, only date of birth and date of death were significant. When I used residual rickets, only age, potentials included with age, and then lived childhood with potentials included were statistically significant. So for all three of those, I also had sex, social race, how long they lived in a location, their state of birth, their occupation, whether or not they lived in an asylum. So there were other variables. They were just not significant with this sample. On top of the chi-square and looking at significance and presence, I also did a Spearman's rank correlation to see what variables may have correlated with vitamin D deficiency, but weren't significant drivers of expression of vitamin D deficiency. So a very strong correlation between vitamin D deficiency and race, state of birth, and individuals that lived in a location for longer than 30 years. There was also a strong correlation between residual rickets and date of death, and then again lived in location for longer than 30 years. A very strong correlation between osteomalacia and date of birth. Next, I have a strong correlation between vitamin D deficiency and sex, and vitamin D deficiency and where they lived their childhood. Then a strong correlation between osteomalacia, where they lived their childhood, their occupation. Then a moderate correlation between residual rickets and date of birth. So let's look at these in a little more detail. So if we go into the discussion, some variables that might affect my analyses. Not everyone was present in the census. African American data was missing. This could be because of Jim Crow laws, slavery, war. They did not track the African Americans as efficiently as they did the white individuals or the non-immigrants. And that comes into the next one. Immigrant data wasn't well documented. Some census records had when the individual immigrated, some didn't. There wasn't always exact dates for when an immigrant came into the United States. Another would be that the people collecting the census data could have relied on incorrect information, like asking a neighbor or just driving by that neighborhood. Next, when I was recording my vitamin D deficiency, again, I only included those individuals that had visible lesions that met my threshold. I did not include any individual that was vitamin D deficient based off blood serum levels. I did not have access to that. So there's a chance that some of the people in this population were vitamin D deficient. It just wasn't expressed in the bone. And another thing, the reason I use social race is because of blackness. I couldn't assess melanocyte activity. I wasn't able to catalog people that were considered black into a lighter or a darker skin tone, which could influence, we do know this can influence UVB absorption, because melanocytes' purpose is to limit UV rays from the sun to protect the DNA of the skin. Now, another factor would be societal observations. So when society observed these people, they threw them into a category of either black or white. The next thing I considered when looking at my results that could affect my interpretations would be the presence of cod liver oil and fortified foods. So cod liver oil was a big thing in England during the wars to help prevent rickets. We know that cod liver oil is a really good source of vitamin D, but it was not pushed in the United States. Cod was caught by American businesses, but it was really focused on being extracted and sold to Europe for profit. There was evidence of cod liver oil being available in New York City through advertisements and various programs to decrease rickets, but it was not present in California or Ohio or any of the states around those regions. Which goes into milk fortification. So vitamin D was added to milk in the 1930s sporadically only by certain industry. And then again in the 1940s, using technology and techniques that we have today in all milk. Again, I was not able to find any information in Ohio and California. I was able to find advertisements for California and milk production, but if you look here where it says vitamins, none of them had vitamin D added to them. I did find evidence of vitamin D added to milks in New York City and along with beers in New York City. But again, Ohio and the surrounding states and California and the surrounding states did not have access to fortified milk. So these are variables I don't have to include when I'm thinking about causes of vitamin D deficiency. All right, so actual presence. When I looked at residual rickets, it was most common in white women. All of those white women lived their lives in the north. So it could be UV. We do know that women were less likely to go out in the sun, and when they did go out in the sun, they were completely covered by their clothing. Based on my current sample, I can say this. Now, these results might change if I had access to more women that lived their childhoods in the South. Osteomalacia is similar. It was more common in white men that lived their adulthoods in the North. Now, we do know during this time period, living in the North, it was an industrializing area. So pollution was very common, which could inhibit UV penetration. The majority of these individuals were laborers. They were blue collar, which means they were probably working outside or inside in machinery areas where they weren't exposed to UV. If they were exposed to UV, it was in polluted regions. Again, if I had more samples that lived their lives in the South, those results might change. Finally, white females had the highest percentage of vitamin D deficiency, and white individuals were more likely to be vitamin D deficient. But sex and social race were not statistically significant. The same for occupation. Housewives and laborers had the highest percentage of deficiency, but occupation was not significant. When I looked at where they lived their childhood, when I included the potential individuals, where they lived their childhood, either in the North or the South, was statistically significant. Again, it was significant when I looked at residual rickets, but not when I looked at osteomalacia, which makes sense because osteomalacia is an adulthood disease, not a childhood disease. So my last little conclusion, we know that age, date of birth, and date of death were statistically significant. And when I break those down into certain time periods of date of birth, decade, date of death, decade, Cleveland and Santa Clara, California were both going through industrialization or wartime. When I look at my individuals with residual rickets, 13 of those individuals grew up during times of industrialization. 6 of those individuals grew up during the Civil War. Now, when I look at osteomalacia, 5 of those were adults during the early 1900s industrialization periods, while 8 were adults during World War I and then following into the Great Depression. So these categories correspond with what we understand by factors that limit or influence UV penetration in diet. So finally, in conclusion, biocultural variables can influence one's susceptibility of being vitamin D deficient. And here are my acknowledgments. So I'd like to acknowledge my supervisors, Dr. Joe Appleby and Professor Richard Thomas. And then I would like to thank the collections for allowing me access. And I would like to thank all of my funding bodies for helping me fund this project. If you have any questions or comments or anything, I really look forward to having a conversation with you. So please reach out via email. Thank you.